Assalamu alaikum. Our today's topic is hypertension and antihypertensive drugs. So, if we define hypertension, hypertension can be defined as when a person's systolic blood pressure is greater than or equals to 140 millimeter of mercury, and or their diastolic blood pressure is greater than or equals to 90 millimeter of mercury, or both, on repeated examination. So, sorry. So it says, the definition says, whether the blood pressure, you know that the blood pressure has both like systolic and diastolic arm. So diastolic and systolic blood pressure, it is not necessary for both of them to be raised. A person can be hypertensive if only systolic blood pressure is equals or greater than to 140 millimeter of mercury, or isolated or individual diastolic blood pressure is equal to or greater than 90 millimeter of mercury. Even then the person will be hypertensive, or both. Like systolic is 140, diastolic is 90, the person is hypertensive. Systolic is 140, diastolic is 80, person is hypertensive. Diastolic is 90, this is even 110, then the person is hypertensive. So that is important. And or, so how can we establish the diagnosis? If a person comes to a clinic and his or her blood pressure is 140 by 90, would we label him or her as hypertensive? No. The diagnosis is only established if the above values, these are measured on 3 separate occasions, or in more current guidelines there are also stated that 2 separate occasions. So if we categorize or we classify on the basis of the readings of a patient, systolic and diastolic blood pressure, this is JNC, Joint National Committee Guidelines. This classification is according to JNC 8, the 8th version of Joint National Committee Guidelines. So if what is the normal blood pressure range? It is less than 120 by 80. If it is 120 to 135, 80 to 89, it is pre-hypertensive, and it is 140 by 90, it is hypertensive. It is 140 to 159 and 90 to 99, this is called stage 1. And if it is greater than 160 and diastolic is 100, it is called stage 2. Why do we stage hypertension? Hypertension is staged accordingly, the raise in blood pressure, because it gives us an ease for the treatment, for the pharmacologic treatment, to see the prognosis of the disease, whether the pharmacologic therapy is working or not. All these parameters are being checked through this staging. Then if we see the normal regulation of blood pressure in body, it is directly proportional to the product of cardiac output and peripheral vascular resistance. So blood pressure is determined by cardiac output and peripheral vascular resistance. So if you remember from your knowledge of physiology, what was cardiac output? Cardiac output was the amount of blood that comes out of the heart per minute. If you remember, per minute, in 1 minute. So if that amount exceeds, then obviously blood pressure will increase. Peripheral vascular resistance, on other hand, is the total of all resistances of blood vessels collectively called peripheral vascular resistance. It is just the impediment or the resistance to flow of blood within a vessel. So vessel will resist the flow of blood. So it will give rise to peripheral vascular resistance. Greater that resistance, greater would be blood pressure, because it will take more pressure for the blood to enter in a vessel. So what factors determine the cardiac output? Cardiac output is determined by heart rate, because definition of cardiac output states that it is the amount of blood that comes out of the heart in 1 minute. So heart rate is calculated on per minute basis. If that amount is greater than 70 ml, so it means that if someone is having a heart rate of 60, the person A having a heart rate of 60, person B having a heart rate of 75, and both have 70 ml of blood ejected per beat. So 70 ml will be multiplied by 60 in person A and 75 in person B. So the cardiac output will be different in both. So, and ultimately if cardiac output raises, then it will raise the BP as well. Contractility is the force of contraction. Filling pressure is the pressure of the auric atria, the pressure of the fluid that fill atria, and greater that pressure means there would be a greater amount of fluid. So filling pressure depends on blood volume and venous tone. Greater the amount of blood will be returned by the veins to the heart, and obviously this will increase the filling pressure. On the other hand, peripheral vascular resistance or vascular resistance, there is a greater role of resistance vessels, arteries and arterioles. Arterioles have pre-capillary sphincter and neurohormonal control, like the local factors, alpha adrenergic, beta muscarinic, local hormones, adrenaline, noradrenaline, many other drugs. The factors that cause vasoconstriction and vasodilation. So there are two set of vessels, A and B. This is constricted, this is dilated. So vessel A has more potential to carry more blood because its lumen is widened, while vessel B will carry less amount of blood because of its constricted lumen. So this is how the pressure, if greater amount of or number of arteries and vessels are constricted, these will raise the peripheral resistance. So normal blood pressure regulation occurs on different sites in the body. And what are those sites? So these are the anatomic sites or anatomical sites where the blood pressure is regulated on every single minute, every single given moment. So first is resistance arteriole. Resistance arteriole have pre-capillary sphincter, and these control the amount of blood that can enter into a tissue bed. Then there are capacitance venules. Veins or venules are the vessels that can have a capacity to hold or hold reserve blood. So that is why these are called capacitance venules. Capacitance venules means they have a capacity to hold a reserve amount of blood. So here the blood pressure is being regulated. If you start exercising and your body needs more amount of blood, more oxygenated blood, then capacitance venules have a reserve amount of blood that will come into circulation, that will go into blood because heart rate is greater and you need more blood. So capacitance venules will give off more blood to the heart, and heart will send that blood to the lungs for oxygenation, and ultimately oxygenated blood will come in circulation to cope up the exercise required oxygen. Then pumping output of the heart itself. pumping output of the heart itself is again greater the heart rate, greater would be the blood pressure. So this goes like pump output is cardiac output, again which we saw in previous slide. If someone is having a hypotension, lowering of blood pressure, then the body's first mechanism is to increase cardiac output. Heart rate will be increased. So pumping output of the heart will increase. I gave the example of 60 beats per minute and 70 beats per minute, 80 beats per minute and 90 beats per minute. So you can calculate yourself, if each beat has 70 ml of blood that is pumped out of the heart, then you can calculate the cardiac output of all these persons having 60, 70, 80 and 90. So the most important, the fourth anatomical site, the kidney, the volume of the blood or volume of the fluid that kidney can retain or can excrete out whenever required. And this is done through renin-angiotensin system. Renin-angiotensin system is, we will study it in detail when we will study ARBs and ACE inhibitors. So normal regulation, one of the best depicted and one of the most studied is the baroreceptor reflex. Baroreceptor reflex is for the regulation of blood pressure, minute to minute regulation of the blood pressure. It also defines a postural hypotension and all the factors that need to raise blood pressure or that need to lower the blood pressure at any given moment. So regulation means to keep the process at optimum level. For example, if the normal blood pressure is around 120 by 80, so the normal blood pressure means that baroreceptors are working properly. If that blood pressure drops or fall in BP, baro means pressure, receptor means anything that perceives, that sense. So these are the part of nervous system, and these are connected to the nervous system. Where these receptors are located? These receptors are located in aortic bodies and aorta and carotid sinus, where the blood goes from the heart, directly from the heart. The first areas to receive blood from the heart. So it means that the greatest pressure of the blood would be in aorta and carotid sinus. So that is the best place to measure the blood pressure. If these baroreceptors measure that there is a fall in blood pressure, there is a pumping ability of the heart is diminished or is lower, then they take some action. What is that? This is, here you can see, these are the baroreceptors. These are the alpha or beta receptor or the muscles, cardiac muscles. So in CNS, in nervous system, we have receptors. Then we have relay neurons which take that message. Receptors perceive the message. Then there is a part in spinal cord or CNS. Then there is an effector organ. So in this scenario, baroreflex arc, baroreceptors in carotid sinus receive the message and they send it through sensory fiber into spinal cord in the CV center, in the brainstem. The cardiovascular center is present in the brainstem. So there the information is assessed whether the blood pressure is raised or whether the blood pressure is decreased. So if the blood pressure is high, vagus nerve will be activated, a pathway through vagus nerve will be activated, and if blood pressure is low, then the glossopharyngeal nerve pathway will be activated, and at effector organ, if vagus nerve is activated, it will activate parasympathetic nervous system and acetylcholine, which will decrease heart rate, while if the blood pressure is too low, then this will release at the effector organ norepinephrine. This will increase blood pressure. Then we have renin-angiotensin system. This we will discuss in lateral slides. So, types of hypertension. The first we have discussed the classification depending upon the readings of the blood pressure. Now the types. There are two types. One is essential or primary hypertension. There is no specific cause of hypertension is found. This accounts for almost 85 to 90% of the patients. While secondary hypertension, patients with specific etiology or the cause are said to have secondary hypertension, for example, hyperaldosteronism or renal artery stenosis. So, secondary 10 to 15% patients are suffering from secondary hypertension. So, for example, if you see what is the difference between two, how can we be unaware of the specific reason of hypertension? We know that hypertension can be caused by salt intake, sodium can cause, but what are the underlying mechanism? What actually shifts the change? So that is not known. That is why the patient will be put on essential hypertension. So these all could be the potential secondary causes of hypertension, which means that if someone is having any one of these disease, he can have hypertension in secondary to this disease. For example, if we take hyperthyroidism or diabetic nephropathy, renin producing tumors, because renin can cause retention of fluid. Any hyperthyroidism, like thyroid increases metabolism and many other things. So pheochromocytoma in that it is a tumor of adrenal gland. In this, from the adrenal medulla, norepinephrine and epinephrine will release in a greater quantity. So this will cause vasoconstriction, increased heart rate, cardiac output will increase, and ultimately what will happen? Hypertension. Liddle's syndrome. Liddle syndrome is a rare genetic disease in which a small sodium transporter is overexpressed, and it keep on reabsorbing sodium. So it will increase the sodium level in the blood or hypernatremia. So this will cause pathophysiology and pathogenesis. Hypertension, for example, smoking can cause endothelial activation and dysfunction. If starting from here, endothelial activation and dysfunction. Endothelial means it is the innermost layer of the vessels, or is called endothelial. So if this does not work properly, endothelin or endothelium can release EDRF, endothelial derived relaxation factor, or it is also called nitric oxide. If nitric oxide is released, it causes vascular dilation or vasodilation. So if there is a dysfunction of endothelial wall, then this can cause no release of nitric oxide, and ultimately vascular or vasoconstriction can occur. This can cause hypertension. These two factors, for example, diabetes, hypercholesterolemia, and smoking can cause endothelial dysfunction. So thereby they can cause hypertension. Cell membrane changes, insulin resistance, increased growth factor, all these can contribute to hypertension. Then there is increased cardiac output and peripheral vasoconstriction. Ultimately, for example, if all these factors, sympathetic overactivity, in sympathetic overactivity, sympathetic nervous system will act or will function more or overactively, which will release norepinephrine, and ultimately this can cause hypertension. But how sympathetic overactivity can occur? This can occur due to renin-angiotensin system, sodium retention, excessive sodium intake. These always increase cardiac output and contribute to hypertension. Etiology is the cause of hypertension. Hypertension is the first cause of hypertension is increased cardiac output or circulatory fluid. If the blood volume increases or cardiac output increases, this can cause hypertension. But how? Increased sodium intake or decreased sodium excretion. This will cause, what will be the consequences of if someone is taking greater amount of sodium or has a lesser ability to sodium excretion. This will increase preload. Sodium homeostasis regulates filling pressure, which determines stroke volume. So preload means it is the amount of blood that fills atria. Greater that amount, greater will be the preload. And this is the sodium. Sodium is osmotically active substance, so which increases filling pressure. If filling pressure is increased, or the pressure or the volume that fills the heart increases, so it will ultimately increase the stroke volume. Stroke volume is the amount of blood that is pumped out of the heart in each single beat. Remember this. Pressure natriuresis, again natriuresis is the excretion of sodium. Increased blood pressure in peritubular capillaries, increased hydrostatic pressure, and this all these factors are due to increased sodium intake or decreased sodium excretion. So this will ultimately increase peritubular capillaries are in kidney. Increase hydrostatic pressure at the cost of high blood pressure. Then new resetting point of water excretion and sodium excretion. So ultimately less amount of sodium and water will be excreted, so it will contribute to hypertension. Aging nephron after the age of 40, every 10 years 10% of nephrons become non-functional. So this decreases the filtration surface. Then there is RAS. RAS stands for renin-angiotensin-aldosterone system. This is activated by decreased renal perfusions. Renin is released. Renin will cause angiotensin 2, which is a potent vasoconstrictor. Then hyperactive sympathetic system, we have discussed it already. Then endothelial dysfunction. Again, endothelial dysfunction, change in nitric oxide release, that is endothelial derived relaxation factors. If nitric oxide is released from endothelium, it will cause vasodilation and increased endothelins. Endothelin is a hormone, is a factor that causes vasoconstriction or increased endothelial tone. Decreased bradykinin, decreased prostacyclin. These are the mediators. So major causes of these effects are diabetes, smoking, and prolonged raised BP. And other factors like atrial natriuretic peptide, stress, obesity, low birth, less amount of physical activity, all contribute to hypertension. Complications of hypertension include many. These include stroke. This is a transient ischemic attack or stroke. or this is if hypertension is left uncontrolled, untreated, this may result in left ventricular hypertrophy, congestive heart disease, or coronary heart disease, congestive heart failure, because continuously pressure is being applied on these surfaces and ultimately can damage. On the other hand, apart from brain and apart from heart itself, hypertension can damage retina, which can affect vision. This is called retinopathy. Hypertension can cause peripheral vascular disease. It can cause continuous constriction of the vessels, and it can damage the kidneys as well. So there are two major renal failure causes. One is diabetes, other is uncontrolled hypertension. So treatment of hypertension, the target blood pressure is less than 130 to 85 millimeter of mercury. This is the preferred outcome. There are 6 major groups used at present are diuretics, beta blockers, ACE inhibitors, alpha blockers, angiotensin 2, and calcium channel blockers. We will see the detail and the classification of the drug in next episode. Thank you very much for your patience